Yeah.
And she said, I really don't think that you're going to get to forget radiology. I don't think you will get into any field of medicine at this point.
Welcome to Specialty Stories. My name is Dr. Ryan Gray. I'm excited to have you here today. I'm even more excited to share a great guest, actually an alumni of the great New York Medical College where I am an alumnus from. We have Dr. Deepak Sudheendra on our podcast today. Dr. Sudheendra is a vascular and interventional radiologist and surgical critical care specialist. A nice little dual specialty there. And we talk about why he kind of went down that path. He also has 4 years of general surgery residency, which is unusual. And we go into a conversation about changing residencies and a little known secret that I kind of knew about, but I've never really confirmed with anyone. And he confirmed it with me today. We start the conversation by how Dr. Sudheendra got into interventional radiology to begin with.
Well, I was actually had just started my 4th year of general surgery residency. I was a categorical general surgery resident in Washington, D.C. At a major trauma center. It's part of Georgetown University. And I really wanted to do cardiothoracic surgery. My father's a cardiothoracic surgeon, and I wanted to follow in his footsteps. And I felt that going into medicine, I had a good overview of a lot of different specialties because almost everybody in my family is in medicine, and you name the specialty, we have it in our family. But as I was starting my 4th year, I started to see advancements in medicine, and especially in cardiothoracic surgery. I was seeing a lot of the advancements that were taking place in interventional cardiology, and how many patients were not necessarily going for open heart surgery, but having a minimally invasive, procedure done. And my father was near towards the end of his cardiac surgery career. And he said to me, once he saw that I was sort of having some doubts, he said, look, you really need to look at what is going to be big in your lifetime of medicine. And in your lifetime of medicine, minimally invasive is where it's at, whether it's interventional cardiology, interventional radiology, or something endovascular. Open surgery will always be needed, but the future is minimally invasive. And at that point, I said, I'm young, and I personally did not want to do any other surgical subspecialty. And so I made the decision to leave general surgery, which was the entire hospital couldn't believe that I was leaving. At this point, I was going to be chief resident in a year. But I chose interventional radiology because initially I thought when I thought of interventional cardiology, it so happened that I was told that none of my 4 years of general surgery counted, and that I would have to start all over and be a medicine intern. And at that point, I said, well, one of my friends who was interventional radiology attending said that there's an accelerated pathway for surgeons to do IR. And so that's how I got into IR.
A lot of people in your shoes wouldn't even consider leaving. This fallacy of sunk costs. Like, I've gone this far in my general surgery, I might as well just do it and suck it up and live this career. This is kind of outside of normal specialty stories questions, but there are lots of students who just are deathly afraid of making the wrong decision, right? We go to medical school, potentially have a specialty in mind. We go through medical school evaluating and trying different things and maybe hating all of them or loving all of them. And then we have this huge decision at the end where we apply to specialties and say, this is what I want to do for the rest of my life. And there are some people who just that doesn't fit their personality. There are some people who still don't know. How much of an issue was it for you? Not necessarily to decide because you made that decision, but to actually go through the process of switching specialties.
Oh my God. Ryan, I always say I will write a book about this because I learned so much about the system and how I don't think we do a good job of educating medical students about picking a specialty and all the things that are
That's why this
involved.
podcast is here.
Uh, yeah. So so let me tell you when I decided to switch, it was probably the hardest decision I've ever had to make because I love being in the operating room. I love operating, and um, I thought, I never thought that this would be me wanting to switch because of being exposed to almost every specialty of medicine. I felt that compared to most medical students, I had a fairly good grasp of the pros and cons of all medical fields.
Mm.
And, the one thing to keep in mind is there's no such thing as a perfect field in medicine. Every field has a pros and cons, but it's what's going to be best for you and your personality. And I really felt that I was losing part of my identity by not being a surgeon in the sort of common sense of the word. And when I switched, um, I actually found that it was very difficult to switch. And there was a part of me that sort of had this surgeon's ego that, I'm a fourth year surgery resident, and now I'm going to be switching into IR and radiology. This will be very easy for me to do. And there are, at least at that time, this was in 2005, there are about 128 radiology programs in the country. I applied to all 128. It's a lot of money.
Thank you, AAMC. Or the AAMC thanks you.
Yeah.
Yeah.
Yeah. And you know how many interviews I got? I got one. And it was a courtesy interview from our alma mater, New York Medical College.
With Dr.
And
Racklin, is that her name?
Dr. Racklin, and she remembered me from that school, and she was very upfront with me.
Yeah.
And she said, I really don't think that you're going to get to forget radiology. I don't think you will get into any field of medicine at this point. And I kind of looked at her, what are you talking about?
Yeah.
And she said, the little secret that nobody tells you is that Medicare pays for you to train for a certain number of years. That's where all the
I was
GE
gonna ask you
comes
that.
from.
I was gonna ask you that. That's this thing I've always heard is the training dollars. I think we know most people, CMS pays for those spots, and that's why it's so hard to switch. Is because now the hospital is paying for you.
That's exactly right. And so
Yeah.
she said, you have effectively used up 4 years of medical GME funding. So with hospitals hurting for money, a fresh medical student has a better chance of getting a spot in any field over
Wow.
you. And so she said, my advice to you, Deepak, is to, look at things outside of medicine, business, law, whatever you want. But I don't see you practicing as a physician.
Wow.
And I was like, oh my God, what did I just do? Because I had already given up my general surgery spot. I was doing IR research at the National Institutes of Health. And I was besides myself. Like, how am I going to, this is how I identified myself. And I really enjoyed being a physician. What am I going to do now?
Yeah.
So,
Yeah.
so my advice, I guess in that regard is, to leave, if someone feels that they've chosen the wrong specialty, and it does happen,
Mhm.
leave early, the first year, so that you're not in that, position of using up the GME
Yeah.
funding, and there will be sometimes an entire year of a residency where someone may not enjoy what they're going through. And, I encourage them to, to talk to their attendings or counselors or friends and family, because they will get through it. But that's very different from saying, I really made a mistake and I do not want to do this specialty and I want to switch into something else.
Yeah. So I'm sure someone listening to this or watching this is on the edge of their seat. Well, how did you end up getting a residency? Did you work for free? Like, how does that work?
Yeah, so I'll tell you, one of the things is, really, I have learned is connections help a lot, and being very nice to people,
Yeah.
and genuinely nice. And what happened was, uh, well, first I had to get a research position, which was not hard or not easy to do. And being in DC, I said, well, the two biggest names in the region were the NIH and Johns Hopkins in Baltimore. So I went to Hopkins, and they did not have any research positions for me. And then I went to the NIH and spoke with the chief of IR there. And he said, I don't have any money to pay you.
Yeah.
He said, you would have to work for free. And I told him, well, I couldn't do that. And so I kind of, went back. And actually, at this point, this is maybe 3 weeks before I was leaving my residency. I was in the emergency room, and one of the ER physician who called me to the emergency room to see a patient. I was very friendly with her, and she said to me, and she's an Indian woman, and there's a reason that's important in this story. She said to me, she said, Deepak, is it true that you're leaving us? And I said, oh my God, the word kind of spreads quickly around here. And I said yes. And she asked me what my plans were. And I told her I wanted to go into IR. But I'm not sure how that's going to happen. I'm looking for research positions. And she said, well, did you find one? I said, no. And but I said, I just interviewed at the NIH, but it doesn't look like that's going to work. And she said, who did you interview with? And I said, you wouldn't know him. And I mentioned, the gentleman's name. And she looked at me and she smiled and she said, Deepak, she said, he's my husband.
That's awesome.
And I was like, what? And she said, I go by my maiden name at work. And she's like, let me talk to him. And that evening I got a call, and he said, why didn't you tell me you worked with my, with my wife? And he said, don't worry, we will find funding. The NIH will find funding. Why don't you come on board? So I spent a year there. And when as I was doing the radiology application process, there was an accelerated program that I mentioned called the Direct Pathway that was for surgeons to go into IR. And you would do 2 years of surgery, 2 years of radiology, and 2 years of IR, and you would get boarded in radiology, diagnostic radiology and IR. So I thought, let me do that program. There were only 3 programs in the country: Northwestern, I think UC San Diego, and I think Tufts. I'm blanking now, or Harvard. And so I interviewed at just one of them, and they took their own surgery person. So my father, who's always been a guiding force for me, and has always been very aggressive. He said to me, "Why was this program started?" And I said, well, the Direct Pathway program was started because there was a real shortage of IR throughout the country. Mm-hmm. And they wanted to attract more of a surgical mindset to the field as we were doing more and more complex cases. And so he said, well, Deepak, if life doesn't present you with an opportunity, you have to create the opportunity yourself. So I wrote a letter to all 128 radiology programs in the country and said, the ACGME has approved this Direct Pathway program. Would anyone consider starting it and taking me as their first fellow? And nobody responded. And several weeks went by, and then I said, you know what? Let me send it again. Maybe it went to their junk mail or something like that.
Yeah.
So I sent it again, but this time I sent it from my NIH account instead of my Gmail account.
Nice.
And 30 institutions wrote back to me. And the University of Pittsburgh Medical Center wrote back and said, we're not familiar with this, but why don't you come talk to us? And I went to Pittsburgh and I gave them a little PowerPoint presentation on what the program is and that it will be funded by ACGME. And so they said, well, you rank us number one, we'll rank you number one, and we'll take you. And that was my into the radiology field. And I matched at UPMC, which is an outstanding radiology program. And the month before I was about to start, the program director called up and he said, Deepak, I hate to tell you this, but we are actually closing our IR fellowship. We will not be able to offer you this accelerated direct pathway program. And I was like, oh my God, what's going to happen now? Can this get any worse? And he said, but the match is a legally binding contract. So you are welcome to come here and do 4 years of diagnostic radiology and then go elsewhere and do 1 year of interventional radiology fellowship. Compared to just doing the surgery in the accelerated program, I didn't have to do, but I was going to do 2 years of radiology and 2 years of IR. And so I said, with my GME funding problem, I said, you know what, I will take it.
Yeah.
And so I did 4 years at University of Pittsburgh, and then I came back to DC to George Washington for my IR fellowship.
That's awesome. I'm glad we took that little detour because what that hopefully shows a lot of people is just continued resilience and yeah, I think some people may go, oh, your dad's a doctor, so you had some ins, you had some connections, but you obviously went out there, did the work, and you're like, let's make this together. I think that's the best part of it. So
yeah,
that's great. What are some of the biggest myths or misconceptions around interventional radiology?
I think the biggest thing, the misconception, and I think it's warranted to a certain extent, is that we are just proceduralists and really know very little about medicine. We're sort of like your car mechanic and do a procedure and we don't really follow up at all. And there is some truth to that in how interventional radiology started. And I think people have to understand how interventional radiology started was that it was purely a diagnostic field. It was called diagnostic angiography, and or special procedures is how it would be referred to. And when it first began, we could not really treat anything in IR. We were the people who told the surgeons where the problem was. Is there a bleeding vessel? We would do an arteriogram and say, look, here it is, but sorry, can't really do anything. And but as surgery advanced, our field also advanced, and IR really developed as being the specialty that got the surgeons out of trouble. When someone has a problem, they come to us, and it's not just surgery; it's all fields now. And so we really have to think outside the box. So we kind of became the doctor's doctor in some ways. And with that, the advancement in IR has led to us now seeing patients and setting up offices, just like any other specialty. But it is not 100% widespread. But it is the future of our specialty. And so I think for a lot of other specialists, they don't really know that there are a lot of things that we treat, other conditions that we treat, and that we're not just the PICC line service or the abscess drainage service.
Yeah. And you also do critical care medicine. Is that a normal thing for IR docs to do, or is that just something where you had an interest and so you went and made it for yourself?
Yeah. And, I have to, generally IR does not do that. And when I was doing my surgical residency, the hospital that I was at, the surgical residents got an inordinate amount of training in surgical critical care. So when I left surgery during my 4 years of diagnostic radiology, I did not want to lose my clinical skills. So unbeknownst to my program director, I actually moonlighted 6 nights a week at at two local hospitals as a surgical critical care moonlighter for cardiac surgery, and then was actually hired as an attending for weekends. When I was in, I think, my third year of radiology residency. So while I was not, operating, I was, still doing a lot of, bedside procedures and just managing critically ill, patients.
Yeah. What traits do you think lead to someone being a good IR doc?
Well, I think there are a number of traits that are unique to IR. They're the general traits that I think all physicians, have to have. But specific to IR, I think it's really knowing how to think outside the box. A lot of the things that we do are trying to clear up problems that many other specialties have not been able to fix. And they're coming to us and saying, "Look, we cannot fix this surgically or medically. Is there something that can be done endovascularly?" Or the common thing where people will come down to IR and say, "Can you just sort of come up with something?" Well, they don't even know what to ask for.
Yeah.
They're just like, "You guys do a lot of things. Can you just do something to try to help this,
Stick something
patient?"
in something and put something
Yeah,
somewhere.
yeah,
Yeah.
right. So, so I think there's a lot of ingenuity. I think that's what has kept IR as a very progressive field. I always, I say that we are the most technologically advanced field in medicine, and I think you have to enjoy coming up with solutions, new solutions to old problems.
Yeah.
Uh, and then I think also seeing patients. I think not having there's a different mindset between a diagnostic radiologist and a interventional radiologist.
Mm.
I think you have to really more have a surgical mindset than more of a diagnostic radiology mindset.
Yeah. For the students listening, we've been talking about IR and all of these procedures and things, but we haven't really talked about the types of pathologies, the types of issues that you are treating. What are patients coming to you for? What are physicians referring to IR for?
So we have two kinds of procedures that you could sort of group things under. And at the University of Pennsylvania, I think our practice is very robust in that there are a lot of inpatient procedures that we do that I think most students may see on their rotations or they may call us about. And that's your vascular access, your abscess drainage, your feeding tubes, nephrostomy tubes. And those are the things that help make a hospital run. You need someone to do those procedures, and we do them minimally invasively. The patients don't have to go to the operating room. GI bleeds, trauma, embolizations. Then there's the whole outpatient world where I don't think most students, really understand that we do. So, for example, one of the biggest things in interventional radiology right now is oncology, what we call interventional oncology. And that is treating liver tumors, hepatocellular carcinoma, metastatic cancer to the liver, lung cancer. And we treat this with procedures that are known as ablation, or where we take a needle and we burn the tumor, or embolization, chemoembolization, where we inject chemotherapy or radiation beads directly into tumors through the arteries. So oncology is big. Women's health, uterine fibroid embolization is very popular, and it really helps save a woman from having her uterus removed. And then peripheral vascular disease, that is an area where you have overlap with other specialties such as vascular surgery and cardiology. But what many students may not know is the procedure of angioplasty, which everyone has heard of. Angioplasty was actually invented by interventional radiology. Uh, and so peripheral vascular neuro IR stroke, comes within our realm. Pulmonary embolism, thrombolysis. So there are a variety of procedures that we do. My area specifically is treating deep vein thrombosis, venous disease, and I actually have about a 1 year wait list of patients.
Wow.
My practice is extremely robust.
Yeah. So basically, it sounds like if you can get to it through an artery somewhere or maybe a vein, then
Yep.
IR could potentially treat it.
You've got it. The patients. When I see them in the office, I see about 25 patients a week in the office,
Mhm.
and they will ask how the procedure is done. And I tell them, I'm going to put a catheter at your ankle, and I'm going to take that catheter all the way through your veins, through the blockages, up to the right atrium of your heart. And they just, they're like, oh my god, they're like, how do you get, from there,
It's
all the
just
way
like
up
getting on
here?
the highway. You take this turn, you take that turn, you
Yeah,
end up where you want to go.
exactly. Exactly. And they're like, and you're not cutting me? Like there's no incisions. Like
Yeah.
just 2 or 3 little IV punctures and that's it.
Yeah. That's awesome. What does a day in the life look like for you? Is it pretty typical with clinic days and surgery days or procedure days? What does that look like?
So, I think days in the academic center are very different from days in private practice. So I can really just comment in the academic center. So I practice 100% IR, which means I do not do any diagnostic radiology other than reading some vascular studies. So I am doing cases all day. My day, I'm generally at the hospital between 6 and 6:30, and our day starts at 7 a.m. And we'll generally have a conference of some kind, and then cases start at 8. And we go from 8 to about 6, doing cases. And that will be a mixture of inpatient cases as well as our private patients, those that we see, in the office, and follow up. I do cases 4 days a week, and Thursdays are my clinic days where I will see, somewhere around 25 patients in the office. These are new patients as well as patients that have done procedures on and they're coming in for follow up. And these are patients that also we follow just about lifelong. And that's, something else that people may not know that we do in IR, that depending on the disease that you're treating, and since I treat vascular disease, once they become your patient, they're mine for a very long time.
Yeah. So you have to like that long-term care of patients. That's interesting.
Yes.
So you mentioned the training path a little bit already through the accelerated program, the 222 kind of program. And then it sounded like the normal training pathway is do your diagnostic radiology residency and then a 1 year fellowship. Is that the typical pathway?
That was a typical pathway, and now things have changed as of about maybe 3 years ago now. Even the direct pathway that I did or was planning on doing has gone by the wayside.
Mm.
Now, IR has become its own specialty. And what I mean by that is you have to match from medical school.
Wow.
So, and it's called a DR, IR, diagnostic radiology, IR, interventional radiology pathway. And you match into that from medical school. And during your diagnostic radiology years, you will do several months of interventional radiology, as well as things such as critical care, perhaps oncology, transplant, other things that the typical diagnostic radiology resident would not do, where all 4 years of their radiology training they're doing purely diagnostic radiology. The IR residency person is doing more clinical rotations in addition to their diagnostic radiology rotations.
Okay. So that's interesting. So it's its own beast now, which
It's
kind of
some
shows how important it is.
Yeah, yeah, and 3 years ago. It's either 2 or 3 years ago. This residency, DRIR, was the most competitive specialty to get in all of medicine, and just going to show how popular IR has become.
Yeah. What's your take on how a student can be competitive for one of those spots?
So, one, I think, is knowing very early on. And so, how do you do that? And this is where I think the counseling comes in for medical students. The two big things in medicine are: do you want to do procedures or do you not want to do procedures? So you sort of have to figure that out, first.
Yep.
But once someone decides that they want to do a procedural field, whether it's a surgical field or IR, then I think that they owe it to themselves to really come and check us out. Not only us, but check out all the different procedural fields to see what's involved, because we all make assumptions of, oh, this is what I think urology is like, or GI, or or what have you. But you really don't know until you've done a rotation. Now, you can't do a rotation in every single field of medicine. I wish we could, but you can, just shadow. Even if you just spend 1 or 2 days with someone in IR, it can give you a flavor to say, hey, you know what? This is a little different than I thought. Maybe I should actually do an elective, in this.
Yeah. Interesting. So as you have gone through this process, what sort of things should an osteopathic medical student do to overcome any sort of negative bias out there?
I think that's really going more and more by the wayside. I've worked with some wonderful osteopathic physicians. We have osteopathic fellows in our program, and I think the main thing is, if you are aggressive, you're intelligent, and you are hardworking, resourceful, that's what we want to see.
Yeah.
Whether you have an MD or a DO after your name, really doesn't matter. In our program, they'll still have an equal chance. I understand there are certain parts of the country where it may be different, but
Yep.
That's generally hasn't been a problem.
Yeah, that's awesome. For the future primary care doc out there, what do they need to know about IR to help their patients help you in the future?
So, I wish, primary care has also changed, where, primary care physicians used to round in the hospital.
Yeah.
And it was an opportunity for not only primary care specialties, but the specialists, for everyone to commingle and interact, whether it was in the cafeteria, the lounge, whatever.
Yeah.
And now you don't see that anymore. And so everyone's, in their silos. And so the primary care specialists, they don't know how much IR has evolved over the past 20 years and what we are capable of doing. And at the same time, it is not conceivable for us to go to their office and talk to every single, PCP in the community. So I think one thing is, reaching out to interventional radiologists. And, if they have patients where they're not sure of what can be done, sometimes even just calling the local hospital and reaching out to the interventional radiologist to ask them, because we interact also with every field of medicine in the hospital. So even if we can't help, we most of the time will know who can help you.
Yeah.
So I think that's one thing. The other is, which I think is more on our part, is as a society, I think IR needs to do a better job of trying to educate physicians in other disciplines as to what we do.
Yeah.
I'm the director of the medical student elective here at the University of Pennsylvania, and one of the things that I tell students, we have a lot of students who are not interested in IR who do our elective, and they are going into internal medicine. And And I tell them that, your goal over the time that you are with us is not to learn the technical aspect, but learn what it is that we do. What are the indications? What is the scope of practice? Because you can only treat what your mind knows.
Yep.
And you can only refer to a specialist if your mind has that knowledge.
Yep.
So if you are seeing a patient, you're an internist and you are seeing a patient with severe post-phlebitic or what we call post-thrombotic syndrome after extensive DVT, and they are debilitated and can barely walk, and you have now scrubbed with me as a medical student and you've seen what things that I can do to fix that, you'll say, oh, you know what? I know that IR may be able to treat someone with chronic DVT, and I'm going to refer my patient to them.
Yeah.
So you're providing better care for your patient.
Yeah, definitely. It's important. What do you like the most about being an interventional radiologist?
I've been practicing now since 2011, and not a day goes by that I'm still amazed at what we can do without incisions.
Yeah.
So, when I was doing surgery, I was doing a lot of laparoscopic surgery, and I would be amazed at, look at what we did. We did a laparoscopic gallbladder or a laparoscopic colon resection, and we have these anywhere between 3 to 5 laparoscopic ports where we put our trocars in, and we did this surgery, and now I'm just suturing those up. Now I'm like, and that was amazing to me. And now I can completely rebuild someone's inferior vena cava and iliac veins, and all they have is a couple punctures.
Yeah.
And and I'm like, oh my God, look what we did inside this patient's body, without an incision. And to me, that is not only amazing, but it just shows how much medicine is advancing and continuing to advance.
What do you like the least?
Couple things. It does get tiring wearing lead. You're wearing 20 pounds of lead constantly. There's radiation exposure, although I'm very good with all the shielding and everything. But the one thing that really does bother me is what we've already sort of discussed, is there are so many patients that I feel that we can play a role in helping, but the medical community doesn't even know what we do.
Yeah.
And because they don't know that, they won't refer the patient and will, may tell them, look, nothing, can be done for you.
Yeah.
And that's not true. Many times we can help. And I think collectively, again, as a society, we need to do a much better job of reaching out to the medical community. And, if you want to say bragging, maybe it is bragging, but it's also educating so we can better serve the patients. Some patients we can help and some we won't be able to help.
You just got to spend the big bucks like the pharma industry.
Right, exactly.
And then the patients will be begging, be like, hey, doc, I watched a commercial that talked about IR as the potential cure for my whatever, my claudication. Yeah. Can you help me here?
Yeah.
Oh, just picture IR commercials like pharma commercials. That'd be awesome.
The other thing that's...
Yeah, go ahead.
So the other thing that's really great is the collaboration.
Mm-hmm.
We interact so well with a lot of specialties, and at Penn we have a very good working relationship with our surgeons. It's not where the surgeons come in and say, you do this because I told you to because I'm the surgeon. It doesn't work like that. At our institution, it's very collaborative. And sometimes we could say, you know what, we will offer, look, this is how we can help your surgical patient, or no, this is not a good idea to do this. And we have many minds, coming together. And that collaboration is really nice because you learn a lot from the other specialists as well.
Yeah. Any last words of wisdom for the student listening to this now who you've piqued their interest into IR?
Well, I think, Again, for anyone considering a field in surgery or any procedural field, I really advise them to come check out interventional radiology in their institution. If their institution doesn't have a robust radiology program where we're seeing patients and having an outpatient, office practice, um, they should, really consider maybe, going elsewhere, for audition elective to learn more about it, because that's really the future of IR. And even in our own institution, other specialists, when they see that we are seeing 20, 25 patients in our clinic, they're saying, like, what do you mean you guys have clinic? Like, who in the world are you following up? You're following up on the abscess drain? And it's like, no, these are our private patients, cancer patients, peripheral vascular patients.
Yeah.
So I think that is something students should consider. And the other thing is just picking a specialty in general. What I tell our students at Penn is there is no other profession where you're investing almost $250,000 into an education, and you owe it to yourself to really investigate as many fields of medicine as you can before you graduate, even if it's just for one day, because you want to be able to walk out of med school graduation saying, you know what, I am confident in the field that I have chosen, and not constantly wondering, what if?
Yeah.
What if I'd chosen this? What if I'd, chosen that?